And so it is important that all of us learn something about this condition and how to manage it. So the learning objectives of this particular interaction between us are how to define asthma exacerbations, how to recognize the clinical presentation of an acute severe attack, recognize the risk factors for an acute severe attack, having recognized it, how to manage it, and very importantly, how do we prevent future attacks of acute severe asthma. So those are our learning objectives for today. We also have other terms. These are called difficult to treat asthma and severe asthma. And these have become a very important area of research and of practice. Difficult to treat asthma is defined as asthma that is uncontrolled despite being in GINA step 4 or 5 treatment. That is, the patient should be receiving at least medium dose or preferably high dose inhaled steroids and must be on a second controller medication. That is either oral corticosteroids or a theophylline or some drug like that. And it requires such treatment to maintain good symptom control and reduce the risk of exacerbations. We also recognize severe asthma, which is a subset of difficult to treat asthma. And severe asthma is defined as asthma that is uncontrolled despite maximal optimized therapy. And you've already treated all the contributory factors, or despite the person giving high-dose treatment, as soon as you try and reduce the high-dose treatment, these symptoms worsen, the asthma worsens. But what we are talking about today is not difficult to treat asthma or severe asthma. We're going to focus only on acute severe attacks of asthma or asthma exacerbations. So what is the definition of an acute asthma exacerbation? It used to be defined in Crofton and Douglas's previous edition defined it as acute severe attacks represent progression of the airways narrowing to the point where the patient is distressed, at rest, and may have signs of cardiac stress, basically a hemodynamic disturbance. So these are severe airway narrowing, and the patient obviously must be distressed even when he's at rest and not only when he exerts himself. And they also may have features of hemodynamic compromise, and if these are there, then it was called an acute asthma exacerbation. But these days we rely more on the Global Initiative on Asthma, or the GINA. And GINA 2019 defined these, fairly long definition as you can see above, but I'll summarize that into saying there are 3 important features. There's a progressive increase in symptoms. And what are these symptoms? These are shortness of breath, cough, wheezing, chest tightness. There's also a progressive decrease in lung function. And these changes in symptoms and lung function is a change in the usual status of the patient sufficient to need a change in treatment. So symptoms increase, lung function decreases, and these changes are so much that they have to be treated by a change in the usual treatment of the patient. And it's important to remember that in asthma, you do have variations in symptoms. You do have variations in lung function. And these are not enough to call it an acute exacerbation or an acute severe asthma exacerbation. What are the symptoms as already defined? There's worsening breathlessness, there's wheeze, there's cough, there's chest tightness. And features of the hemodynamic compromise are that the person is getting restless. There are autonomic features like sweating. And if this continues, the person can have a drop in blood pressure, the person can feel dizzy, and even lose consciousness. But there are some important signs that we need to pick up. When you look at the patient, often they are anxious. They're refusing to lie down though they are tired, so they're orthopneic. If you watch them, they have accessory muscles in action, typically the sternomastoids. The alae nasi are flaring with each breath, and all the muscles of the chest are in action. The person is often sitting, arms at the side, in so-called tripod position, and trying to breathe desperately. The chest, when examined, is overinflated, and because of the hemodynamic compromise and the autonomic dysfunction, there is a pale, sweaty person. The person is also obviously breathless. He may be tachypneic, and here he has very great difficulty in expiration. So the person often goes, and that is pursed lip breathing. There's also cyanosis. There's pulsus paradoxus. On examination, you may find bilateral wheezes and crackles. But if you don't hear these, it's an even more alarming sign, and this is a silent chest. And these three, cyanosis, pulsus paradoxus, and silent chest, are often considered very ominous signs, and these need urgent action. So what are the risk factors for developing an acute exacerbation? There are patient-related risk factors and there are doctor-related risk factors, and both need to be addressed. This came out from an inquiry report published in 2014 by the Royal College of Physicians. The answer was, why does asthma still kill? And they reviewed all asthma deaths in the country. And it's important to remember that asthma still kills, not only in the West, but also in India. And here, in fact, we have a major problem with asthma deaths. So what are these risk factors that we need to focus on in order to prevent these exacerbations? So people who have a long history of asthma are at greater risk. People who've been hospitalized multiple times for asthma. Typically those who are poorly compliant with treatment. People who are accustomed to saying, oh, this is me, this is my asthma. I will accept this degree of disability because I know this is me. I'm not going to take any more treatment. A very important group are those who are unable to gauge the severity of an attack. So you don't know when they're bad. One of my patients, I remember, and I still have a great deal of guilt about him when I was in the United Kingdom. We were doing a study of this drug called oxytropium, and I needed to check his lung function. And I asked him, do you feel well enough to do a lung function test? And I'll take a minute to go and get the machine. And the machine was in the same room. And he said, Doc, I'm fine. Go and get me this. But he was wheezing when he said this. By the time I came back, he'd had a respiratory arrest, went on into cardiac arrest. That gives me a great sense of guilt, but also taught me a lesson. Some patients are unable to gauge the severity of an attack. And you need, therefore, to use objective criteria and not just depend on how the person tells you he or she is feeling. Other risk factors include obesity, psychiatric illness. So these people are often very difficult to get them to understand and comply with their treatment. They're often also smokers, which incidentally happens to be another risk factor for practically every disease. And alcohol and drug abuse is common among them. And even in people who do not have psychiatric illness, but abuse alcohol and drugs, including tobacco, these are all people who can get acute exacerbations, more severe acute exacerbations, and more frequent acute exacerbations. So please remember this list of patient-related risk factors, because these are the patients you must be careful about, because they can come back to you repeatedly, or they can come back to you once, the very severe attack. Unfortunately, there are also doctor-related risk factors. And doctors too, just like patients, can underestimate the severity of an attack. And one of the main reasons we do this is because we don't use objective measurements. So I was trying to do an objective measurement, but you can do a simpler objective measurement, peak expiratory flow rate. And ideally, you must also check the arterial blood gas. In fact, I would say this is mandatory at some point during the course of an acute exacerbation. A very, very important thing is the underuse of steroids. And we know that steroids are life-saving during acute exacerbations. And often doctors and patients are very reluctant to use steroids, and this can cause asthma deaths. There's unfortunately both underuse and overuse of beta-2 agonists. And this is very important that because beta-2 agonists produce symptom relief, very often patient keeps using them and overusing them and relying only on them without taking steroids, which are very, very important to control the inflammation that has triggered off the attack. Unfortunately also, because sometimes beta agonists do produce side effects such as tremors and palpitations, some patients are very hesitant to use them, and therefore they suffer from lack of use of beta-2 agonists. So we should use the optimum amount, neither overuse nor underuse them. The other big problem is the use of beta blockers. And I had a patient who, by mistake, was given a beta blocker when he went and asked for Astelin, because the wrapper of Astelin and Ciplar looked at that point almost identical. This is, as you know, Astelin is salbutamol and Ciplar is propranolol, a non-selective beta blocker. By mistake, the pharmacist gave it to him, and this young man, a very educated young man, was keen to take the tablet, so he immediately took the tablet, ended up with a severe attack and almost died. Fortunately, he was rescued in time, he survived. And a very important part of what we do not do and we should do is educate patients. And poor patient education is responsible for a lot of acute asthma exacerbations, including asthma deaths. There are also other factors. There are social factors. A person who's socially isolated, a person who's unemployed, cannot afford treatment, a person who's going through severe stress. This could be personal, marital stress. It could be legal stress. Stress itself is known to trigger off attacks. But equally importantly, persons who are going through stress often are poorly adherent to their treatment. And of course, illiteracy. And illiteracy, remember, makes our patient education less effective unless we take a lot of trouble. So find out if your patient has understood what you're going to tell him and educate him about this problem. It's very important also to remember that all that wheezes is not asthma. It's an automatic tendency among both patients and doctors to assume that if a person has a wheeze, they're asthmatic. So we must remember that one of the most important causes of a wheeze is acute left ventricular failure, pulmonary edema. So this can often be missed, and that's why it's given the term cardiac asthma, and that's something we must keep always in mind when a person comes to you with acute exacerbation of breathlessness. And I'm not going to go into the details. All of you know how to differentiate between cardiac asthma and asthma, bronchial asthma. Pulmonary eosinophilias need a different treatment. A pulmonary thromboembolism can present with an acute worsening of breathlessness and is often mistaken for being asthma, especially because with the release of platelet-derived factors, it can also produce bronchospasm, and the person can therefore wheeze. Angioneurotic edema causes swelling of the upper airway and produces not wheeze but stridor, but often this is missed. Children especially have acute attacks of bronchiolitis, which is not at all the same as asthma. Carcinoid syndrome, foreign body obstruction, and factitious asthma are all known to be important mimickers of asthma and can present like an acute severe attack. So what is your approach to the patient going to be? First of all, take a history. Asthma is characterized by nocturnal symptoms. Persons well during the day and during the night it starts to get worse. And this is usually early morning. Important. Mimic not soon after you present like an acute. The person becomes breathless. So what is your approach to sit up and take some time to sit down, characterize by nocturnal symptoms. Well during the day, likely that during the night this mimic early morning. Mimic norms, however, as symptoms mimic the person. What is your I find that